We shall now go on to the third speaker, Dr. MERLE Fernandez, another very amazing personality who is the Network Director, Finance and Accounts, and also the Director of LVPI Center of Excellence in Hyderabad. And we are all cognizant of the fact that she is another very dynamic surgeon, and she has a very interesting video to show us. So let's all be glued to it. On to you, Dr. MERLE.
Yeah, hi. Thanks, Chitra, for inviting me to be a part of this meeting, and to the AIOS ARC for giving these opportunities to all of us to be able to reach out to the postgraduate students and others as well. So this was a patient who had actually presented to us initially, and she was monocular for one. She had keratoglobus, and she presented to us with a DM RIP and a descemet membrane detachment, or rather hydrops, for which we initially tried, tried to do a dysmetopexy, but that didn't work. So we had to do a DSEC. And the DSEC itself was very challenging. As you notice in the image before I start the video, was that she had an adherent leucoma and a very limited amount of, cornea for which, through which we had to put an 8mm lenticule. But fortunately, it stuck and it added to the corneal integrity. Subsequent to that, she developed a cataract. So the challenge was now in how do you proceed with a cataract surgery in a patient with keratoglobus who has an adherent leucoma on one side and who has a DSEC lenticule which you need to protect on the other. Also knowing the fact that with the keratoglobus, the tissue is going to be very, very fragile and it's going to give way with, throughout the surgery. You have to be mindful of that. So we took a decision to do a scleral incision, obviously because the cornea was too thin and we wanted to be away from the lenticule. Used trypan blue because it was a total cataract and the pupil was small. So we had to kind of do it under blue. And I made this paracentesis, and you can notice that through that paracentesis, the uveal tissue is starting to prolapse and the paracentesis is slightly enlarged. The sclera is also anticipated to be thin in these patients. So you have to be very gentle when giving this incision with the 15-number blade. And ensure that you don't actually go through and through. You can actually appreciate the bluishness of the sclera here. So we went in with a keratome, and you would notice that there are peripheral anterior synechiae which are pre-existing. So we've taken a spot where this is to avoid that. And this paracentesis, which enlarged, had to be sutured because it would have continued to leak throughout the surgery and affected the chamber stability, and that would have been detrimental to the endothelium of the DSEC lenticule that was there. So we did the gentle hydro, and the cataract, as you notice, is kind of fairly hard, not all that hard, because she was around 45 years old. Made another paracentesis through which we were able to rotate that. And you notice now we have an additional challenge of a small pupil, but obviously we can't make can't use a Malugan ring, nor can we use iris hooks because it would entail using multiple paracentesis. So we decided to proceed by kind of supporting that pupil with the Sinski and proceeded with the phaco. So the phaco was not too challenging. Keeping the nuclear fragments all in the center when phacoing, ensure that we were able to remove them and do a phaco in the bag, so that would protect the endothelium. But look what's happening to the paracentesis here. You notice that the paracentesis is extended significantly. The uveal tissue is prolapsing through that. But instead of coming out and suturing it, I decided to proceed because additional suturing also would mean that we would have to kind of pass sutures through that area. That may cheese wire and cause problems. So I decided that I would just restrict myself to managing with this leakage that was happening. So we managed to do the phaco, push back the uveal tissue, and then we had to do remove the cortical matter. So I sutured a part of it here because otherwise it would have continued to prolapse throughout. And so the point we have to note is that we can't keep repeating these sutures as well, because the sutures tend to cheese wire, since this is a very, very thin peripheral cornea. But there was no other choice at this point of time. The decision not to do a full thickness graft and then proceed with cataract surgery was taken because the large grafts, as we know, they always have problems. So unfortunately, the cortical aspiration was edited significantly, but we put a single piece. She had opted for, she was a non-pink patient, so we had to put a PMA lens in the bag, and that managed to go in fairly well. The cortical aspiration was done with bimanual, and then following that, this was sutured. the remaining part of the surgery was fairly okay because we had to suture the scleral tunnel as well. And post-operatively, she was doing well. Throughout the surgery, we would have to keep using a viscoelastic, which would coat the endothelium, so that would protect the lenticule from further problems and ensure that the chamber was maintained throughout the surgery. Otherwise, again, there would be damage to the endothelium. And in this situation, because the sclera is so elastic, one would have to suture all the openings that we've created. So we've sutured the sclera as well with 10-0 nylon sutures, as you are seeing here. Yeah, so that's all I had for this video. Post-operatively, she's doing well. To this day, she maintains vision of around 21-25, and she's ambulatory with that. The other eye, as I mentioned, she had lost it to crisis. I think she had a globe rupture because she had keratoglobus in that eye as well. So I'm happy to take any questions.
Yes, that was an amazing video and with so much of learning in it. Of course, the way you handled the made it scleral incisions and how you dealt with the iris prolapse and all that. But I think you could have also had the challenge of a very deep AC, and some of these are highly myopic also. So you could have had a challenge during the surgery, but that apparently was not evident. It just showed that the iris was fairly floppy, but it wasn't a very deep AC. And of course, I did wonder why you placed a rigid IOL. You could have placed those hydrophilic foldable IOLs instead of creating a larger incision for that. But then I wanted to ask more important questions. Of course, the DSEC, when I saw the video, I just wondered why a DSEC in a keratoglobus unless there's been a hydrops, and that's what you've had. So what are the biometry challenges in this eyes, and how do you plan for an IOL? Of course, these patients could be amblyopic too, so need for extreme level of accuracy is not there, but how do you plan these IOLs?
So in this case, because her cataract was fairly dense, we couldn't actually do an IOL master, and it was done manually with the ultrasound. So we were able to do that. We use an immersion technique so that you can get a little more accurate value when you're trying to get the axial length measurements. And again, because she had DSEC, we opted for an IOL power which is a little more on the minus side. Yeah. We went with about -1 diopter of myopia, which would take care of the hyperopia that's induced by the DSEC lenticule. But again, there is no data on this because this the DSEC post keratoglobus is extremely uncommon. We published this as a case report because we didn't come across any cases where DSEC was done. Hydrops has been reported, but not DSEC following keratoglobus and hydrops. So the issue would be depending on the corneal thickness as well. And you can't measure how much of hyperopia you're going to induce. So we just went with about -1 diopter of myopia. But fortunately, she has not landed up with significant, refractive error post-op. She also has the adherent leucoma, Chitra. So that was why the AC was not becoming very, very deep. The adherent leucoma was kind of preventing that, and it remained, irregular because of it.
Yeah. The other question is, of course, I think adaptive fluence has not come into our country, but Namrata and Dr. MERLE, I wanted your thoughts. Would you think of doing a cross-linking in case of keratoglobus, or these corneas are too thin to think of doing any of these things?
I think, MERLE, you want to take that, or? I think they are quite thin, and really we don't do keratoglobus because it's a pan cornea kind of a picture. And if the patient has reached, I think the patient must have been old also in this case. Like MERLE said, DSEC in keratoglobus is the way to go for a corneal decompensation, but is also very uncommonly reported. And when the cataract surgery has been done, suppose by somebody else, and you are doing a case of keratoglobus, then you can be in for surprises, because at times what happens, the moment you put the AC maintainer, you see fragments here and there. Somebody else has done a surgery. Of course, here MERLE herself was doing the surgery. Challenge is always the pupil will not dilate, because like in myopes, you have a breathing kind of a pupil. So it keeps, mid dilating and then just slightly dilating and doesn't quite dilate from limbus to limbus. And it's like a brittle cornea syndrome kind of a thing. Wherever you make incision, it becomes radial, rather than remaining there. And you have to keep suturing them. MERLE so beautifully, handle that case. It's very difficult. I know that I'm not saying all the people here are good, but really for cornea surgeon also, it's very difficult to do such kind of cases.
Have you all ever noticed these eyes being large, that they are often confused to be ophthalmic eye in the earlier days? And have you seen some of these keratoglobus eyes having had a trap surgery done anywhere? Like you all must have seen in institutions, keratoglobus patients more than is seen in a general practice.
I think those kind of things you rule out when the patients are younger. So there is always a confusion between ophthalmos and keratoglobus or megalocornea for that matter. But then I think because of the intraocular pressure, you do.
Can you please, all of you, be unmuted, excepting the expert panel?
So, that kind of a challenge is solved by the intraocular pressure measurement, especially in the younger age group.
Yeah. And what are the chances of globe rupture in these eyes?
Chances are that even with the trivial trauma, they can go in for globe rupture, especially keratoglobus or even brittle cornea syndrome. They can be, the globes can rupture. And so we always like to tectonically do some kind of a procedure for them. Maybe a tuck-in lamellar keratoplasty if it is too thinned out, so that there's some tectonic support onto the cornea.
So on to the expert panel. Any other questions?
Ma'am, I had a question.
Yeah.
I agree with you, Chitra, on one thing, that foldable intraocular lens could have been done so you won't have to enlarge the incision.
Yeah, true.
Yeah.
I know.
Yeah.
That is a question I keep getting asked whenever I present this video.
Whenever you present.
But that was a
Yeah.
very good.
But
Ma'am, could we have a lovely surgery? Absolutely amazing. Could we have used a BX ring instead of multiple iris retractors? Because that's less bulkier also.
But the issue is because of the adherent leucoma that she had, so it would have not got support in the inferior part, and there was no visibility there. So then you have a question of how do you support it in one area, when you can't visualize. I don't know if any of the others have an experience with this.
no, I agree. It would have been very difficult to put a BX or a Malugan there.
Just a couple of questions. I mean, a very difficult case and very well managed. I was just thinking that, whether this is a situation because the cornea is global thinning and weakening, and the central incision, which was quite large, held up, and while both the side ports gave way. So maybe this is a situation where even the side ports have to be made clearly. That might be a take-home message, in the sense that here she did make a scleral incision, main incision, side ports created a lot of problem. Maybe you have to go back in these cases and meet those incisions clearly. A second
But the
point is
ballooning
that,
of the conjunctiva would have occurred if you have made a
you
scleral.
can always make a small incision on the conjunctiva.
Conjunctiva can be viewed.
That could have been
True.
handled.
Yes.
And the
Yeah,
second
but she
point-
also had passed, Dr. Ramurthy, she also had peripheral anterior synechiae. So we were trying to find areas where we could enter without causing damage to the uveal tissue in that part. So that was the other problem that we were facing.
Right.
Though I agree, yes, definitely scleral incisions or a much posterior incision for the paracentesis also is something that we should consider in these cases.
In these cases also,
Right, I
you
mean-
have those retained fragments, small ones, when you do phaco in such cases, because they get camouflaged underneath the opacity or underneath your, main incision or underneath your side port. Plus, everything is so voluminous, so you have to keep putting viscoelastic to actually dilate the pupil. And when it is dilated, for that split of a second, you know what is happening, and then it again becomes mid-dilated. So you have to keep replenishing the viscoelastic agent if you have heel or nothing like it.
And
So-
I'm not a cornea surgeon, but I had a doubt in the sense that I know that DSEC graft induces a certain amount of myopic shift, and you emit a myopia of about, make a correction of about 1 diopter. In your case, since the DSEC implant was already there, and you are subsequently doing a cataract surgery, was this correction in the IOL power really necessary? And as regards the IOL power calculation itself is concerned, just like in KC or other situations or post-classic situation, here is again the anterior-posterior relationship of the corneal curvature is disturbed. So I would have gone with a true K formula, Barrett true K formula, as far as the IOL power calculation is concerned. Not that it would be bereft of any errors, but maybe that would have limited the amount of error that could have been faced. And of course, using a foldable lens, now I think good Indian foldable lenses, hydrophilic, are available at around 200 rupees. And we have, even for our CAM patients, we are completely shifted from using these, PMA, large PMA lenses.
No, hydrophilic lenses, I think, should not be put, because what if you need to repeat a DSEC or a DMEC, and if you use air for getting the grafts to attach, then air with the hydrophilic lenses is known to have cause calcification or known to cause glistenings. So that is why I think in all cases where you're anticipating or doing or will want maybe Fuchs or keratoglobus desec like this, there I think hydrophilic lenses should be avoided. MERLE can comment
Yeah,
on.
no, I agree. So we don't use hydrophilic IOLs in D-second because of the lens intra-lenticular opacification or glistening that occurs. And to Dr. Ambuti's question about the lenticule per se induces hyperopia, though the question here will be because the overlying cornea is thin. So what is the ultimate thickness of the cornea that you're left with once you've put in a lenticule? Whether it still induces that hyperopic shift or not is a question. But the problem is you can't measure. And we did an ASOCT, the corneal thickness is around 570, if I remember correctly. So there is some amount of thickness that has been induced by this lenticule per se. And so therefore we went in for a myopia. We corrected her made her myopic, in other words.
Yes. Yes, I think that was a truly wonderful video and lot of discussions came through, and I think we covered the entire gamut of the challenges of cataract in a keratoglobus eye. Thanks so much, Dr. Merle. Do stay connected so that you could participate in the other panel discussion.